A reporter on a street corner at 5 a.m. watches a mother drop to her knees screaming for her child trapped in a fire. It was the moment he realized this wasn't just a story to write. Listen into this episode to hear how it shaped a career in mental health policy, why this issue crosses party lines, and what real community-led change looks like. You're listening to the PHEC podcast, episode 460. Welcome to the Public Health Epidemiology Conversations podcast, where we have honest conversations with public health professionals who are creating meaningful impact in communities around the world. They know that the field of public health touches everything. I'm your host, Dr. Charlotte Hughes Huntley, and today we're exploring the fascinating journey of our guest and diving into another conversation that bridges different perspectives with the practical wisdom you need to fuel your impact. Greetings, everyone, and thank you for joining me on this episode. My name is Dr. Charlotte Huntley, and I lead an epidemiology consulting firm that supports large nonprofit organizations. We specialize in a variety of community assessments, also workshops and trainings, ultimately helping our clients communicate their health information in plain language to their community partners, as well as the broader communities they serve. The support we provide often falls in the category of strategic planning and sometimes capacity building. It just depends upon the needs of our clients. Please reach out to us through our website, drchuntley.com. We'd be happy to meet with you and explore how we might be able to support your organization. Links will also be provided in the show notes. I'm really excited to introduce you to my guest on this episode. Zack Stoycoff started his career as a journalist covering crime and community in Oklahoma, and one early morning moment changed everything. Now he's running a mental health policy think tank. He has built something rare, a bipartisan approach to systems change in one of the most politically divided times in recent history. In this episode, we explore how he moved from the newsroom to policy work, what it means to help communities lead their own mental health solutions, and how sitting down across the table as humans, not opponents, opens doors that funding fights alone never will. Let's connect my conversation with Zack right after we highlight our sponsor for this episode. Public health is about connection. And now you have a space built just for that. The PHEC Podcast Community app is where public health professionals come together to collaborate, share ideas, and support one another. Inside, you'll find exclusive events like Power Hour, which is our virtual co-working event. It helps you connect with others and boost your productivity. You'll also have direct access to conversations with other public health professionals from around the world, and even guests from previous podcast episodes. We're more than a podcast. We're a thriving community. Be a part of it. Download the PHEC Podcast Community app today and join us. Hi, Zack. How are you? Welcome to the podcast.
I'm well. Thanks for having me.
Yeah, it's my pleasure. We were chatting just a little bit before hitting record, but I am ready to dive in. Would you just take a moment and introduce yourself? Just tell us a little bit about who you are and what you do.
Sure. So I run a mental health policy think tank in Oklahoma called Healthy Minds Policy Initiative. We are really focused on changing mental health systems in the state of Oklahoma and being a part of the national conversation about how we do that at the federal level. And we work both at local communities and at our state capital to pass policies, draft legislation, community coalitions around these questions that have really plagued society for quite some time. How do we really transform and move the needle in mental health outcomes?
Very important work. And I have so many questions for you about the work that you're doing now. But on this podcast, I always love to roll back. It's really nice to see where people are now and think, oh my gosh, that's so, like, they just rolled right into what they're doing. But we often know that the path is a little zigzag sometimes. So one of my favorite questions really is around that pathway. So do you remember when you first thought about, and I know that your background is public administration, but that's the work that you're doing is very public health. So do you remember at a point when you first learned about public health or public administration and thought, this is what I want to do? Was it as clear as that?
No, certainly not as clear as that. So I actually started my career right out of undergrad as a reporter, a print journalist for the Tulsa World in Tulsa, Oklahoma. And my very first job was getting up because you have to pay your dues early as a reporter in your career and getting up at 5 a.m. to cover the police scanner, go and do breaking news and crime reporting. And I remember at the time, this was at the height of really methamphetamine being manufactured, especially in Oklahoma, manufactured in housing and homes and apartments and things like that. So every morning, virtually every morning at 5:30, there would be a call. There's a meth fire, another fire to go out to. We would all the reporters in town would go out to it. And I just remember standing on the street corner. You get kind of jaded as a reporter, waiting for the fire folks to the police folks to come tell you what had happened. And I look over and there's a woman screaming and crying with her knees on the ground. And she's looking at this apartment complex and she says, my baby is in there. And it's going to be hard for me not to get choked up right now. But that was where the moment, I think, where I realized this is real. This is not just a story I get to write. This is something that is really plaguing our community. This isn't okay. That little thought in the back of my head led me through my career, and eventually I found my way up at Tulsa Regional Chamber, which is a chamber of commerce, the second largest in the state. And then I found myself as VP of Healthcare Policy doing lobbying and advocacy on behalf of business and commerce and healthcare interests in Oklahoma, which was the last job I had before this one, where I really dove into starting to understand health issues and public health issues and why they matter to the economy and the community and how we can solve those issues.
That's interesting. I can definitely relate to what you're saying. There's a point where it's not just something we studied in a classroom or a case study. This is like reality, real people, real situations. When did you pivot or niche into mental health specifically?
We did a lot of mental health policy when I was at the Tulsa Chamber, but really what was fascinating about mental health policies, there weren't as many financial interests tied up with mental health, at least in my state. You had large hospitals and health systems that really weighed in on what we should do for health generally. At the time when I was working at the Tulsa Chamber, there was a big push on Medicaid expansion in Oklahoma, which voters subsequently passed. I was privileged to work on that issue at the Chamber, and we became one of the states that did Medicaid expansion. And then really behavioral health, though, became a question mark. The business community stood up and said, hey, we're seeing these issues in our workforce. We understand the effect of drugs, alcohol, mental health issues in our communities. What do we do about it? And they looked to me, hey, you're the healthcare lobbyist for the chamber. What do we do about it? And we would call the state in and whoever else was the spokesman on this issue, and they would say funding, funding, funding. And the business community didn't necessarily understand why we needed funding and what specifically you would do with the funding. And there were various things that the state had proposed, but nothing quite that seemed to get their interest. In my state and in many others, the business community is a powerful voice at the Capitol. And if you don't have their buy-in, you often don't move the needle on some issues. And so when a funder approached me about launching the think tank that I work on now, the idea of really bringing the expertise around the table to come up with what are the Oklahoma solutions that make sense for our state, that are driven by the data in our state, that are vetted by political leaders and are doable, we can actually get done. That was the first time I truly heard somebody in my state try to articulate a vision that we're going to craft a mental health policy agenda. So the idea of doing something specific and proposing something more than just getting up and yelling at the Capitol and telling them they're doing a bad job, that was really attractive to me.
That is really interesting. So you were approached with this idea because I was going to ask, how did you start Healthy Minds? Let's say Healthy Minds Policy Institute. Get it right?
Healthy Minds Policy Initiative. Yep.
So initiatives. Okay. So you were approached with this idea.
I was.
That's interesting.
Yeah. So there was a funder in town that has a large endowment, the Ann and Henry Zero Foundation. They're longtime givers in Tulsa philanthropy, Oklahoma philanthropy, and they've had an interest in mental health as well as hunger and homelessness housing. And they had had some experience on the hunger side, really creating a systems change, policy-oriented organization that would do collective impact model kind of work. And they wanted to do that with behavioral health. And so they brought me on and some consultants nationally that we continue to work with to build that up in the state and see what that would look like.
Nice. So let's dive into a little bit more about where you are now. Give me a picture of the kinds of work that you're doing, some examples, maybe if you could, and could speak to some wins if you'd like, brag a little bit. But yeah, just help me understand more about what you're doing day to day.
Yeah, like in a lot of states, and in particular a lot of small states, really hasn't been that much work done on these issues in Oklahoma. The state has made some progress in a lot of areas, but I have the easiest job in the world if you look at it like, hey, I can throw a dart at a dartboard and hit something that needs to be done with behavioral health in Oklahoma, right? So it's almost hard not to get wins, especially when you have both the Republican legislature and the Republicans dominate state politics in Oklahoma and Democrats who do have a voice in our state. And you get both of them singing from the same soundbook, right? They want to make progress. And everybody, they might have different reasons for doing so. They just want the bill to vote on. Tell me what to do. Tell me why so that I understand it and I can defend it. And that's what we attempt to do. We attempt to get the data, we attempt to develop the playbook, and how do we actually move needles on this issue. And so the very first thing we did was we unfortunately responded to COVID because we were launching in 2019 and 2020. And so that's the very first thing we did is we said, hey, we believe based on the research that shows us what happens after natural disasters, that COVID is going to have a substantial mental health impact on our state. And so we put out some research and said, hey, you've got to start working on this issue. One of the first things our state did with that information was to enshrine into state statute what the federal parity law said. So now we have state regulated health insurance plans in Oklahoma that, much like the federal regulated plans, have to produce no additional barriers for seeking behavioral health care and that issue of parity for behavioral health. So that is in law in Oklahoma. We've built on that since then. We've built on research that shows that we've actually done a secret shopper analysis of insurance networks in Oklahoma and showed that we could only reach 35% of behavioral health providers listed in network from the 5 largest insurance carriers in the state. And so as a result of that, we worked with the state legislature and the insurance industry and passed some legislation that requires insurance companies to pay out of network for in-network behavioral health care if a behavioral health provider is not available in a timely fashion in network. And so that bill was actually just adopted by the state of Utah. They're very proud to see that legislation going into other states and other red states that want to make a difference in this issue nonetheless. We've passed significant improvements in funding for psychiatric residencies, as we know that the clinical workforce issue is not going to go away. We've passed legislation that requires every school district in Oklahoma to have an MOU and a partnership with a local community provider to address student suicide crises in the classroom. So we know that 80% of Oklahoma districts, school districts, now have such a plan in place for student suicide reduction. And we're seeing some big gains. For example, in one area of the state, we've seen an increase in referrals to treatment from schools up 490%. So good work happening at the Capitol there. And then really, I think we're most proud of in a lot of ways is our local community work. Because the legislature loves, when I say this, they're not the solvers of every problem. And they can't be. Communities have to adopt new practices and take leadership into their own hands. And so that's what we do. We go into communities, we help them analyze their data, come up with a plan that works for their stakeholders, and start to make progress. So in Tulsa, for example, we've stood up the state's first children's emergency room for mental health. We call them emergent recovery centers. It's like much like a crisis center for adults, but it's child and family focused. That was the first one in the state. The state adopted that model and took it statewide. We piloted a ability for law enforcement to not have to transport individuals to a bed, a mental health bed, so that law enforcement aren't having to cuff you in the back of a car when you're just needing care. We've had clinicians embedded in 911 centers in Tulsa and Oklahoma City, actually, that have reduced substantially the police involvement in mental health issues so that we can get clinical support to those folks who have mental health crises on the street instead of law enforcement coming out and responding. We've actually seen a 40% reduction at our local hospital in terms of children not showing up at the emergency room with behavioral health issues anymore, which was a major issue post-COVID. So that community level problem solving is really paying off, and we're very proud of that.
Well, that is a huge accomplishment. I do a lot of community level work, working directly with community myself. And I know that communities want to lead and want to be supported and want to be involved, not just organization coming in and telling them what to do, but oftentimes communities have their own solutions. Is being able to partner and have the ability for conversation, communication, and funds and resources to bring those solutions together that are in a sustainable way. So it sounds like we've had several examples of that.
Absolutely.
Given the shifts politically across the country last year, 2025, into this year, you've mentioned the bipartisan policy and organization and how they've been adopted across really beyond Oklahoma, which is wonderful. I'm just wondering, what are some of the maybe challenges that you've had to address, and how have you been able to gain this bipartisan support in probably one of the most challenging times to do that, I think, in 2025 especially? Just would love to hear you speak about that.
It's a great question. There are the culture wars issues and the social issues that get the headlines, but the work happens on the ground with really practical solutions. And yes, sometimes there are adverse effects, maybe more than sometimes there are adverse effects on what's happening on the ground as a result of the dialogue that's happening, whether it be at the state level or the national level or wherever it's happening. But we can make progress on those practical things. And I can tell you that two people who disagree vehemently on those culture wars issues in the headlines can sit around a table and agree on a very practical solution that works for their community that has nothing to do with politics. And we're seeing that happen every day in Oklahoma. So, for example, there certainly are some misconceptions, I think, about what's going on in schools with regards to mental health. Are we involving families appropriately? Is it, you hear things like, hey, you're doing critical race theory in schools, or whatever you think social emotional learning is, or DEI, these buzzwords. But when we actually show people what's happening, and we're talking about mental health clinical care that needs to happen in schools, we're talking about a very systemic way of understanding what students need and meeting those needs in a clinical way. You get two people around the table who are ideologically opposed, and you start to see the clouds part and realize this is just science that's happening. I mean, it's medical science. And if we get the families involved, we can dissolve any kind of issues that we might have. So around the school mental health issue in particular, I've seen a big move in Oklahoma in terms of an initial maybe misunderstanding of what was going on. The threat sort of flags raised from one end of the political spectrum to really then understanding there's accountability in a system here. There's mutual accountability between the schools and the families if you do it right, that there's family involvement if you do it right. And we often tell people, hey, that there's no world in which a student should be receiving anything without the parents involved. In a mental health crisis, a student in crisis is a family in crisis, and the family needs something too. And if we start to break down those barriers, we can make progress. And so I don't know if that's evading your question too much, Dr. Huntley, but we definitely see those really practical. Let's get out of the social issues. Let's talk about what's needed on the ground. And that just breaks down some of those issues.
You're reminding me of is a conversation I had with a couple of state legislators. This was last summer, actually a moderated session where we were Policy Action Institute was the name of the event. And we had some state legislators there and we were talking. And I can't remember which one, but someone made a comment that, we're connecting on human level. And so it sounds like what you're describing, I want to break it down just a little bit because I think this could be helpful for people who are trying to fit in and figure out how to, including myself, how to bridge some of these gaps and try to come together in a way that we can have a conversation, we can advance some issue forward and we can find that commonality. So when you say, kind of sitting down at the table, is that what you're essentially referring to? Just really connecting on this human level, this mental health and our children. To me, that's connected on a human level, talking about this issue. It's not really a blue or red issue. It's a human issue.
It's getting past the talking points, right? And getting past the terminology and the words that we have these associations with on both sides. And realizing that once we get past that, we kind of get past our own trauma response associated with what we think the other side is doing with regards to that terminology. And you get into, okay, this isn't that. What we're talking about is something else, and it's this, and it's what matters for our community.
So do you think that is really just kind of sharing the stories that maybe story examples of situations with involving children helps to kind of get the conversation moving?
Stories absolutely help. I think when Healthy Minds approaches a conversation, we approach a problem rather, we bring a framework to the conversation. We bring, hey, I'm going to show you in writing what this looks like. Here's what the process looks like. Here's the accountability structures. Here's where the resources go and where they don't go. All goes well, A, B, C, D happen. Does anybody oppose A, B, C, D? And nobody says, I oppose A, B, C, or D. They say, I oppose this thing over here that I think is happening, but it's not part of the framework. So I can focus on the framework. And that seems to dissolve a lot of that.
I see. Okay. That makes a lot of sense. Thank you for going down that little bit of not really a rabbit trail. I think it's very relevant to what we're talking about, but that helps me to understand. Are there any particular programs or specific policies or anything that's top of mind that's right now that, is getting your attention?
Yeah, with behavioral health, here's one of the reasons why it ends up being such a bipartisan issue is because whether you care about people and that's your primary focus and you lead with your heart, or whether you care about resources and you kind of lead with your brain, this issue matters on all sides of that. And so behavioral health is an issue, much like public health generally, right? When we don't do anything about it, we tend to funnel resources to the worst crisis and the worst possible scenario, the worst so we let somebody escalate in their need to the point where they've got permanent brain damage. We're now treating them in the ER, in the inpatient bed, in the jail, and they're in and out of police. And we've got some studies that show police spend 50% of their time potentially on mental health and substance use related issues instead of doing their job. You start to realize that this is a problem of misspent resources in society. And that is an issue that really appeals across all sections of the political ideology. We all want government to work effectively and not spend as much as we could spend. We want to be effective and efficient with our dollars, no matter where you land. We want people to get well. And so with behavioral health, I can draw the argument that if we can somehow shift the resources from the emergency room to, say, primary care or prevention, we will be so much better off as a society. If I could tell you that we could prevent 78% of marijuana use and 68% of methamphetamine use, nobody would disagree with that. And that's the reality of evidence-based prevention programs in schools. But to get to the heart of your question, I think one of the things that we're focused on really intently right now is primary care. And we know that the data show us that 47% of the time when somebody dies by suicide, they had seen a primary care physician in the last month of their life. So primary care should be the entry point to all healthcare, right? But for some reason, we're not doing it well for behavioral health. And there's something called the depression cascade, where 45% of people who go into primary care offices are even detected who have depression. And then even fewer of those are treated, and then even fewer of those are treated effectively. So we got to do better there. And so one of the things that my organization is very proud of, we're about to announce this. We received a $5.5 million grant from our Tobacco Settlement Trust in Oklahoma to launch the Oklahoma Integrated Care Resource Center. And it's a partnership with some national organizations, including Meadows Policy Institute, National Council of Behavioral Wellbeing. And we're going to be looking at actually funneling resources to primary care settings to change their approach and change their model so that we have psychiatrists who are delivering care in primary care across thousands of patients in Oklahoma. Instead of a one-on-one psychiatry visit, we can actually affect the care in primary care settings without those external referrals and get wholly better outcomes, both on costs and from a patient health outcome perspective. So we are launching this center. We believe that Oklahoma can do this well because it's a small state. And if we can affect, a few clinics, we can affect a significant portion of the state's population. So we're really excited about that.
Wow, that's something to be excited about for sure. You'll definitely have to keep me up to date on how that progresses. I'd love to get an update in the future. How long is the project?
It's a 3-year program, but we hope to continue it beyond its initial funding cycle.
Okay. You blink and 3 years will pass by. So,
That's true.
but I'd love to get a progress update on that. So we were talking a little earlier, and this may have been before we actually hit the record button, but you mentioned some of the work and activities includes community needs assessments. So is that something that you do on a regular basis? Is that specifically like what community? Can you speak a little bit more to about what that looks like?
Yeah, we use a traditional public health approach to this because it's tried and true. We want to get stakeholder buy-in, leadership buy-in in the community. We want to put data behind the problems, and we want to use that data via the assessment to develop an implementation plan. And then we want to make sure there's a group that's coordinating all the players, that's keeping people accountable to the goals that are associated with the plan, and it's moving it forward, trying to resource those things moving forward. So we serve as that backbone entity. We serve as that group that both puts the assessment together, evaluates progress, keeps stakeholders engaged and moving forward. We've done that in Tulsa, which is where we started. We've done that in Oklahoma City. Now we've just launched an Oklahoma City mental health strategic plan that's got buy-in from city leaders, philanthropy, and other community leaders across the city. We've done that in Edmond, which is the largest suburb in Oklahoma City, and we're starting that soon with 2 other communities in Oklahoma. The result of that work, really those sorts of projects have resulted in this kind of, I mentioned before, these really practical system enhancements, like the new level of care in Tulsa or clinicians embedded in 911 centers. And because of that work, we now have Oklahoma as a state that 30% of our residents are served by a 911 center that has 24/7 access to mental health clinicians. So we're able to de-escalate a mental health crisis if you call 911. We're able to send mobile response teams who are mental health professionals instead of law enforcement. We've got facilities for you to go to if you need a facility. So we're very proud of that. And in Oklahoma City in particular, this new project we have going, they've seen about a 57% reduction in police interaction on mental health issues, which is huge.
Congratulations. That's a tremendous amount of accomplishment, especially in, I think, a really challenging time. There's a lot to be learned. And thank you for answering all of my questions and kind of doing a deep dive. I think partially it's for our own understanding, but I think for my audience listening, I think this models a lot of what folks are trying to do and trying to accomplish. So we'll make sure to have your connection information in the show notes because I'm sure you may have some folks reaching out to you for more conversations about that. Is there anything else that you'd like to share about Healthy Minds Policy Initiative? I really like that I didn't think to ask, but you think we should know about?
Yeah, you hit the nail on the head. We want to be partners. We're actually engaged in multiple conversations across the country right now in helping other states launch something that looks like what we've done in Oklahoma, or at least informing some strategies that various funders and treatment providers are trying to formulate in those states. We really want to see this work move forward in other states. We really want to help other states learn from our lessons and failures as well as successes, because we think that both, and I particularly have a passion for small states that get forgotten in some of these conversations. There's lots of resources in the big states, and there's lots of policy entities and change agents and things like that. But in the small states, there's not. But the reality is, you can make so much progress in a small state. I mean, 2 cities can reach 50% of the population of a small state. You can make transformative change, move the needle in a small state much more than you can in a big state. And if funders could sort of realize that and devote some of those resources so that we have examples in small states, and in particular small red states, we have examples of this kind of change, I think we can start to move the dominoes across the country.
Yeah. I appreciate that. And I'm thinking, I may have to follow up with you with some specific connections, but I think that some people are going to be really wanting to connect. And I like the approach. I like that you're looking to partner. I really strongly believe that, especially, always, but especially now, we're stronger together. So being able to, instead of reinventing the wheel, partner with resourceful organizations, people across our cities, boundaries, our states, and really being able to make those advancements that we really want to see and the impacts that we want to see in the communities that we are serving. So,
Absolutely.
Yeah, thank you for that. As we wrap up, I will, like I said, share connection information with you and your organization in the show notes for this episode, and I'll tell everyone how to connect in just a moment. We have a very diverse audience of listeners, and I'm going to ask you to, for just sharing maybe any bit of advice, encouragement, tips, just something that we could leave the audience with. We have anywhere from students, just figuring out what they want to do with their degree and how they want to have an impact in the field, all the way up to people who are 30 plus years in the field. We've got entrepreneurs, we've got private industry folks. So we've got really a mix of audience in our audience of listeners. But is there just any general tip or word that you'd like to leave with everyone as we wrap up?
Well, the work you're doing is important. Data-driven public health work needs to continue and needs to move forward. I would say look outside the field of public health too for allies, for folks who can sort of translate and get some other leaders on board. We mentioned the business community earlier in the podcast. Business community can be and should be a big support for public health, right? Because this is about workforce availability across the country, and every community is lacking workforce, right? We can get people healthy, we can get them working. Those sorts of conversations and connections. I would say just look outside, continue what you're doing, but look for those partnerships because I think they can be good.
That's wonderful. Thank you so much, Zack. I appreciate your time and those really wise words. I appreciate that. Thank you for being here.
Thank you. It's been a pleasure.
I really hope you enjoyed that conversation as much as we did. Mental health touches every community, every zip code, every family. And this conversation is a reminder that when we lead with shared humanity instead of political talking points, real change becomes possible. My guest's path from journalism to policy work shows that lived observation, not just credentials, can be the thing that drives you toward the work that matters most. Whatever your role or career stage, the lesson here is the same. find the human story at the center of the issue and build from there. I encourage you to connect with Zack and learn more about the work that he's doing, and you can find those links to connect with him on the show notes page. The show notes page for this episode, which is episode 460, can be found at phecpodcast.com. Once you're there, just navigate to episode 460 to find the show notes. One more thing before we go. Remember that our podcast has an app and a private community that is independent of social media platforms. So you don't have to be on social media, although our community is very social. This is a place and a space where you can engage with public health professionals around the world. So in addition to being a part of this amazing community, your membership supports the production of this podcast and episodes like this one. You can download the PHEC Podcast Community app in your mobile app store, and it is available for both Apple and Android users. You can also visit phecpodcastcommunity.com to join the community on desktop. All right, everyone. Until next time, have a fantastic rest of your day. Thank you for listening. The show notes page is where you'll find links to everything we discussed in this episode. To find the show notes for all of our podcast episodes, just visit phecpodcast.com.